A new medication is knocking on the door for FDA approval in PTSD, and it isn't MDMA. Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003. I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report, and my co-host, Kellie Newsome, is out sick. She has lost her voice, and we'll miss her today. Last week, we looked at first-line medications for PTSD, but before we venture too far off-label today, let's recap that episode. Medications take second place to therapy in PTSD because therapy has bigger short- and long-term effects. When it comes to medications, some experts recommend SSRIs first-line, while others recommend a personalized approach favoring prazosin first-line if insomnia, nightmares, and nocturnal hyperarousal are prominent, and SSRIs first-line for other cases. The debate, though, does not end there. When choosing an SSRI, some recommend the FDA-approved options first, like sertraline and paroxetine, while others argue that fluoxetine, Prozac, has a better risk-benefit profile in PTSD, with both better efficacy data than sertraline and better tolerability data than paroxetine. There's a reason the experts can't agree. The data just isn't clear in either direction. Today, we're going to look at what to do when those first-line options fail, and here, the data is even less clear. Here's how I look at that. Just how clear the data is going to affect how collaborative I am, as well as how big the risks are. For example, let's take clozapine and lamotrigine. There, the data is clear and the risk is big. There's no ambiguity about whether clozapine causes neutropenia or whether lamotrigine causes Stevens-Johnson syndrome. Those are big risks. So when a patient comes in, say, with low blood count on clozapine or a rash on lamotrigine, I am going to have zero collaboration about the decision of whether to stop those medicines. But when it comes to questions like, should we use topiramate for PTSD, for that kind of decision, collaboration needs to be higher because the risks are not as big and the data is not as clear on what is the right or wrong thing to do. So what I'll do is talk to the patient about the meaning of off-label use, the promising but uncertain studies, and the risks with the medication so we can decide on it together. Outcomes tend to be better when we make collaborative decisions. Let's start with topiramate. In 2020, we published an article in the Carlat Report that recommended topiramate for treatment-resistant PTSD, and I have an update here that's going to take it down a notch. At the time, topiramate rose to the top with an effect size of 0.6 in a network meta-analysis that compared effect sizes for 26 medications across 58 studies in PTSD. That sounds impressive for topiramate. There's a big catch, though. The certainty of this finding is very low because it was based on just 2 small trials with a total of 73 patients. Now, we still recommended it because there was other data supporting topiramate that wasn't included in the meta-analysis, and here's where the story gets more interesting. At least 5 trials were left out of that analysis. 1 was published, 1 came out after the meta-analysis, and 3 were excluded because they involved unique populations, like populations, though, that we often see in practice, treatment-resistant PTSD, or PTSD with alcohol use disorder. And 2 of those studies came out after our review in 2020. So now that we have more data, putting it all together, we've got about 7 controlled trials of topiramate in PTSD, totaling over 300 patients, many of them involving military trauma, and some that ventured into areas where most treatments do not work. Well, where does it all stand? The glass is half full and half empty on this one. Half the studies were positive and half were negative. When topiramate did work, topiramate was most helpful for the re-experiencing symptoms of PTSD like flashbacks, intrusive memories, and nightmares, with less benefit for avoidance and numbing. So I'm not exactly changing our recommendation on topiramate, but the newly published negative trial, that one was negative, and the discovery of this unpublished trial, which was also negative from 2016, does dampen my enthusiasm compared to 2020. Looking through the trials, many of them failed because of high dropout rates, which means tolerability might be the elephant in the room here. So if you look at those failed trials where topiramate did not work, and we just pick out the patients who stayed on the medication, who didn't discontinue it because of side effects, then the results were positive, and it looks like most of the trials are positive. But that's not a lot you can hang your hat on, and it does tell us something about topiramate's tolerability. In my experience, topiramate is a real hit-or-miss medication. It is either very well tolerated or not at all. And the reasons why it's not tolerated are hard to predict. They are many. Cognitive problems, sure, but also dizziness, visual changes, paresthesias, fatigue, and all kinds of psychiatric effects. Topiramate, for example, can cause or treat depression, and it can cause or treat psychosis. There's studies pointing both ways, so this drug is a real wild card, and I would only use it when nothing else has worked in PTSD or if alcohol was part of the picture. In those trials with alcohol and PTSD, topiramate lowered alcohol use by 55% compared to placebo. Topiramate does reduce drinking both in PTSD and non-PTSD populations. And besides alcohol, topiramate also improves other comorbidities that might go along with PTSD, other reasons why we might consider it. Things like migraines, obesity, borderline personality disorder, cocaine use disorder, and various impulse control disorders. Another off-label option in PTSD is to augment an antidepressant with an antipsychotic, much as we do in depression. This is a popular strategy, and it does work, but it's often questionable whether it's the right thing to do for patients who haven't tried the standard treatment, which is psychotherapy, given the known risks with antipsychotics. When it comes to choosing an antipsychotic, the experts agree. Risperidone has the best evidence. But things are about to change on that note. We're going to get into that after I pause for a preview of the CME quiz for this podcast. Earn CME credits through the link in the show notes, and if you don't know the answer to this one, stay tuned. We'll get to it at the end. Which supplements are effective in PTSD? A. Omega-3 fatty acids. B. St. John's wort. C. SAMe. D. No supplements are known to work in PTSD. On June 11, 2024, the FDA accepted a new drug application for brexpiprazole, Rexulti, in combination with sertraline for adult PTSD. The manufacturers of this antipsychotic, Otsuka and Lundbeck Pharmaceuticals, submitted 3 large randomized controlled trials, 2 of which were positive. The dose of brexpiprazole was 1 to 3 milligrams a day, and it was added to sertraline in patients who did not recover on that antidepressant. We have not seen the trials, but the FDA usually approves meds that pass in at least 2 of the trials, so if approved, this may change the game, moving us away from risperidone as the first-line option among antipsychotics. The studies were published in brief abstract form, and here's what we know so far. Brexpiprazole improved re-experiencing, avoidance, negative cognitions, depression, hyperarousal, and reactivity. Now you might notice that sleep is missing from that list. A lot of people do add sedating antipsychotics like quetiapine to improve sleep in PTSD, but I'm going to caution you against that. In the words of a new meta-analysis of meds for insomnia in PTSD, here's what they concluded. Risperidone and quetiapine carry a high risk of causing somnolence without having a clear therapeutic benefit. In other words, it's meaningful sleep benefit that we are after here. Sleep quality, not just sedation. I mean, we're clinicians here. We want to help the patient's health, not just give them the illusion that we're helping their health by making them feel sedated when we've not actually helped them in any other way except changing their feelings while giving them a medication that has nearly a dozen black box warnings. So I would warn against using it just for sleep. For insomnia in PTSD, the recent review in the American Journal of Psychiatry recommends trazodone over benzos and Z-hypnotics, and they see promise in the orexin antagonists like suvorexant and lemborexant and daridorexant. And I agree with the nod to those new hypnotics. These orexin antagonists do look safer than other hypnotics, and in some studies show that they improve not just falling asleep, but sleep quality and next-day cognition, something that we haven't found for benzos and Z-hypnotics. But I was disappointed, on the other hand, that the only randomized controlled trial of these agents in PTSD, it was a small one from 2022, was negative, possibly because of a high placebo response rate, but negative nonetheless. Well, I just mentioned the B word, so let's get into that because benzos are controversial in PTSD. The American Journal puts it this way, quote, evidence for the effectiveness of benzodiazepines is lacking, despite their continued use in clinical practice. Unquote. In fact, there is evidence that taking a benzodiazepine shortly after a trauma increases the risk of PTSD. That study has certainly spread around the world, and it's caused some therapists to advise your patients to stop their benzos out of concern that taking a benzo dampens the benefits of psychotherapy, because we also have data showing they might interfere with exposure-based learning. So whether you're on your own after a trauma and the benzo is keeping you from processing the trauma for your own natural sources of recovery, or you're in therapy and you're doing exposure to process the trauma, it looks like the benzos might interfere with what you need to get done. But as often the case, things are a little more complicated in the brain and in human life than what these studies are telling us. So technically, the therapists do have a point, although the studies on this are actually mixed when we're talking about benzos interfering with psychotherapy. And the studies that are positive looked at patients who started a benzo while starting psychotherapy, not people who were on them long term. My opinion here, which is just an opinion as we don't have definitive evidence, is that we should not start a benzo while starting psychotherapy for PTSD. But if the patient has been on a benzo long term, it is probably not a good idea to taper it just to start PTSD therapy. Coming off a benzo is likely to interfere with cognitive processing just as much as starting one. I'll also remind psychotherapists not to take an all-or-nothing approach to this. I mean, it's true benzos probably interfere with learning, but this isn't a 100% interference. I mean, alcohol and sleep deprivation also interfere with learning. But few therapists are screening for sleep apnea or requiring the patient to abstain from red wine before starting exposure therapy. Life is not so black and white. And just because one of these factors is prescription doesn't mean that we'd have to take an all-or-nothing approach to it. We got a lot to cover here, so let's pause to recap what we've done so far. Topiramate, possibly good for PTSD with alcohol use or other things like migraines or obesity that go along with PTSD. And consider it for treatment-resistant cases where nothing else has worked. titrate it slowly. I usually start 25 milligrams and raise by 25 milligrams a week. Target of 50 to 200 milligrams. You can give most of it at night or give a little during the day. Not a big deal there. But I have found that cognitive side effects are better if you titrate it slowly. Antipsychotics. They're easy to prescribe and often prescribed, but that does not mean these are safe. And we should consider them when the patient has very severe symptoms and other things haven't worked. Risperidone has been the go-to, but we might see that replaced by brexpiprazole in the future. Sleep medications. All right, experts don't really have solid evidence to base their opinions on, but most experts are favoring trazodone and possibly the orexin antagonists for insomnia in PTSD. I would actually say prazosin should be first line there, as it improves insomnia and other symptoms of PTSD. But we generally want to avoid the benzodiazepines as they can make PTSD worse, but we're not going to get all draconian about them if the patient has been on them long term, because we know that benzo withdrawal also makes things worse. The Z-hypnotics are just different forms of benzos, basically affecting the same receptor. We don't really have major studies of them in PTSD. Lunesta, azoplatron had some positive data, but we don't really know which of those to use, and I'm not going to make a strong statement for or against them. So for sleep and PTSD, we really don't know much what to do, but we do need to remember that many of those patients have sleep apnea, and they might be complaining of insomnia because they're not breathing at night. Sleep meds are not going to fix that. Well, let's move on to other antidepressants because it's not all SSRIs and SNRIs. Tricyclics can also be an option in PTSD. Some of these worked even in combat-related PTSD, and the three with the best evidence are imipramine, amitriptyline, and nortriptyline. These also seem to be the three that are most commonly used in practice. The warnings about drug interactions, toxicity at high doses, cardiac and anticholinergic effects all apply to tricyclics here, as well as the drug interactions with SSRIs that can make some of these meds go too high. I usually start with nortriptyline because it's a little bit of a cleaner drug, less likely to cause hypotension. Falls are a big issue with these. But I might choose imipramine first line if anxiety is more of an issue, and in PTSD, it often is. So for PTSD, I might go that way. What about the MAOIs? Well, evidence of the MAOIs is very limited in PTSD. So while they might work, we're going to best reserve them for patients who also have treatment-resistant depression, where MAOIs are probably underutilized. What about complementary and alternative medications, the CAMs? The American Journal article recommends acupuncture, deep breathing, progressive muscle relaxation, mindfulness meditation, and yoga. I agree, and I will add light therapy, Lightbox, to the list, because it has a positive randomized controlled trial from a few years back where it treated military PTSD regardless of the season that it was used in. The dosing of light therapy was similar to what we do in depression, 1 hour early in the morning. If you want to get into that, I keep a list of effective light boxes because most of the ones out there don't really work at Chris Aiken, MD /light therapy. It also tells you how to use the boxes there. You might wonder if the authors of the American Journal paper overlooked supplements in their list of complementary treatments, like I see none of them are there. But no, this was not a miss. I know of no natural supplements with positive controlled trials in PTSD. In fact, I have here on my shelf a big textbook called Complementary and Alternative Medicine in PTSD. So if we're going to find something, it ought to be in here. Let's take a look. It includes a chapter on alternative medications. Let's see here. Melatonin may help, has yet to be supported by direct evidence. I don't know about that. Omega-3s. There was a small open-label study, but it was cut short because patients got worse and dropped out. Okay, not going down that road. SAM-E may prove ideal. Ideal. Based on its mechanism of action, but there are no studies of it. Okay. Maybe some of you know what I think about treatments that are ideal based on their mechanism of action. We can throw that away. Okay, and then we go into lots and lots of vitamins and herbs that they list. Every single one says there are 0 studies in PTSD. They even list magnesium as having positive studies of PTSD in mice. But in mice? And then when I look at the study, it's not even a study of PTSD. It's a study of post-traumatic brain injury, like these mice got their brain shattered, not PTSD. So that's quite a bit of a stretch. Well, maybe some of these things they list here are the future, or maybe the future belongs to Ayakasha. But what is in the pipeline for PTSD? Cannabis derivatives, like CBD oil, actually have pilot studies. So there's a lot of talk about those going around now, and there's a phase 2 trial of CBD underway. CBD is available over the counter. It's also a prescription medication used for seizures called Epidiolex. Cannabis has some positive pilot data in PTSD, but some patients also worsened on cannabis, marijuana. No surprise there. Remember that cannabis refers to the full marijuana plant, which is a mix of nearly 100 cannabinoids, while CBD oil is just one of those cannabinoids and thought to be the safer one. So we'll look forward to more data on both cannabis and CBD oil. Meanwhile, we're going to be listening to a lot of patients who are probably trying it on their own. Moving on to some of the psychedelics, I'm not going to go into detail on MDMA-assisted therapy. It did fail to gain FDA approval last August because of major flaws in the trials. We covered that in a lengthy podcast in June. But there is another medication-assisted therapy that's on the horizon, and it has a lot less controversy around it. It's called reconsolidation therapy, and it combines written exposure with propranolol. You might remember from our recent podcasts that there was some evidence that propranolol prevents PTSD after trauma by improving cognitive processing, seems to enhance learning in the brain. Well, what happens here is that patients write out a detailed narrative of the trauma and then take propranolol, which is dosed by weight, 1 milligrams per kilograms. So average person might take 70 to 100 milligrams. After taking the propranolol, they read that narrative aloud to their therapist. The idea is aptly captured in a quote from the American Journal paper, "Propranolol decouples intense emotions from the recollection of the trauma, and a new memory is formed, which is reconsolidated with a factual narrative, but without the terror, horror, and helplessness and other negative trauma-related emotions. And this new memory replaces the original terror-fueled narrative." Sounds quite wonderful, if it works. The therapy is brief. It requires only 4 to 6 weekly sessions, and it did improve PTSD with a large effect size in a double-blind placebo-controlled trial. This is an exciting avenue. It's dampened, though, by the fact that propranolol was ultimately unsuccessful in the explorations of it as a preventative treatment for PTSD when given shortly after a trauma. Its trials were positive at first, but later negative, and meta-analyses gave it a thumbs down. So before we get too excited about what looks like a really promising approach, and one that lacks the controversy of the psychedelics, let's wait for more data. Another way to enhance exposure-based learning in therapy is with D-cycloserine. That's an old antibiotic that enhances learning at low doses and has glutamatergic antidepressant effects at high doses. So it's being explored for depression as well. They're even developing a potentially FDA-approved version of it that'll combine it with trazodone for bipolar depression. Now, getting into the PTSD studies, those used a low dose, as I said, 50 to 100 milligrams taken 1 hour before an exposure exercise, and I have used it in practice. D-cycloserine has some positive but also negative trials when it's used to enhance the effects of exposure therapy in various conditions, including OCD, anxiety disorders, and PTSD. D-cycloserine is generic, but it's hard to get. If you want to use it, you need to find a pharmacist who is more determined than the average CVS or Walgreens pharmacist. We're talking about independent mom-and-pop pharmacies that can do the extra digging to order it, and then sometimes, because of supply and demand, it ends up being expensive. But if you're persistent, you can get it for your patient. Ketamine has a positive controlled trial in PTSD, while psilocybin and neurofeedback have trials that are in progress. TMS, transcranial magnetic stimulation, probably works. It did so in a meta-analysis of 13 trials, but it's unlikely to gain insurance approval unless it's FDA-approved, so patients will have to pay out of pocket for TMS. Finally, there are 2 procedures to know about: vagal nerve stimulation and stellate ganglion block. These hope to treat PTSD by modulating the autonomic nervous system. They have promising pilot data, but they also have risks, and I don't think they're ready for prime time. Well, that wraps up our series on PTSD. Hope you've enjoyed the journey, and I'm grateful to all who stuck with us through to the end. Send us your feedback and questions of all things psychiatric to asktheeditor@thecarlatreport.com. We read every letter and are always looking for new ideas to cover in the journal and the podcasts. And if you want to subscribe to the journal, you can get a discount with the code podcast@thecarlatreport.com. Thank you as always for helping us stay free of commercial support.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.